Our first speaker today is Dr. Chris Gallagher, and he is a board-certified internal medicine and cardiovascular disease physician. He has dedicated his career not only to patients, but also to physician development and leadership of creating efficient, cost-effective, and high-quality physician networks. Take it away, Dr. Gallagher.
Thanks, Dan, and thanks to everyone for the opportunity to speak to you today. I'll be sharing my screen here, so I'll be bringing up the PowerPoint slide and going into presentation mode. All right. So again, thanks for the time today, and today we'll be talking about telemedicine, specifically launching telecardiology programs and the benefits of telecardiology programs in rural hospitals. I'd like to start out by just doing a quick introduction to the group and of the group, Access Physicians. So Access Physicians is now the nation's second largest physician group that's providing inpatient telemedicine. So we are a physician group, multi-specialty, dedicated to building clinical programs inside of hospitals on 6 core service lines. Cardiology is one of our core service lines, and that's the topic of today. And so we put together an agenda, but obviously the world has changed so much in the last 4 to 5 months post-COVID. And as we deal with those challenges, telemedicine in particular, as everyone has seen, has had an enormous impact. When you look at the weekly encounters that have gone from 10 to 13,000 per week, and within a short month or so, we're eclipsing 1 million visits per week, really speaks to the changes in adoption of telemedicine. This is something that we as a group have been working in a field we've been working in since 2013, and have some knowledge to share, some experience to share, some pitfalls to also share as hospitals think about telemedicine and specifically care of the cardiovascular patient. And so really the goals of today would be reviewing the what, giving some background and basics. Many of this will be review in items that everyone attending today probably already knows, but I think it's important to kind of level set and to really make sure we're all on the same page about the disparities that impact, especially rural medicine, but things that specifically telemedicine can address. But then talk about the impact that well-designed programs can have in hospitals, have a case study, and can also in Q&A talk about our experience. And then also share a roadmap of what we found to be very helpful in terms of launching successful telemedicine programs and sustaining successful telemedicine programs. Quick background on me. So as Ann said, a cardiologist by training. I serve as the CEO of Access Physicians. And as I said, Access Physicians is now the second largest multi-specialty physician group that's focused on inpatient telemedicine. My career started at medical school at Texas Tech, so trained in West Texas, and then went back to my home town of Dallas and did my postgraduate training at UT Southwestern. So completed internal medicine residency and then became faculty. After a year as faculty, pursued a cardiology fellowship, and upon completing a cardiology fellowship, I began a cardiac electrophysiology fellowship. And it was during my time as a cardiac electrophysiology fellow, specifically in my last year, that I kind of went back to rural medicine. So having worked in it and being part of it at Texas Tech in my medical school time, and then fast forwarding to a decade at a large tertiary care center, began working in rural East Texas during my fellowship, really working weekends. And it took me back to my days as a medical student and really reinvigorated my passion for care of the rural patient, and obviously incredible opportunity to do a tremendous amount of good. But obviously the geography really poses a challenge in terms of recruitment, retention, and getting specialists. And it really was something that I felt there was something that could be addressed and tackled, and that we could improve the care. and actually ended up leaving my cardiac electrophysiology fellowship and passing my funded spot to a colleague of mine to continue on. And so to be technically correct, I should say half an EP fellowship, because I really fell in love with the opportunities to work in rural medicine. And here I was a cardiologist and halfway through an EP fellowship and found myself working as a hospitalist in a 96-bed hospital in rural East Texas, and couldn't have been happier. But it's really that change in my career trajectory that led me into building a group that was focused on telemedicine. So really excited to talk to you guys today about our experience, what we've seen work, where we've seen pitfalls, and how any hospital can logically work through kind of identifying opportunities, getting support, winning over the hearts and minds of their medical staff and local community, and implementing successful programs. And so just at a glance, I've talked a little bit about the scope of the group, but we have currently 220 programs, clinical programs in 22 states. We've served 1.7 million patients since we began providing telemedicine services in 2013. And we're supported by 90 non-physician employees. All the states you see in orange are where our physicians are licensed, and each state that has an asterisk are states where we currently have clinical programs. And just to round out the discussion about the group and what we do and services we provide, so teleneurology, hospitalist, pulmonary critical care, maternal fetal medicine, infectious disease, cardiology, and we have 40 hospitals where we are the code blue team, and also manage cross-coverage services. So when one talks about the capabilities and what can you really do through telemedicine, we always like to point to our code blue programs. There's very few things in healthcare that are probably more urgent or emergent than a cardiac arrest. And again, implemented now 40 hospitals where we manage cardiac arrest, where the physician is remote and there's not a physician, nurse practitioner, or PA in the facility. The facility is strictly staffed with nursing and respiratory therapy, and we're able to manage cardiac arrest completely remotely. And so I think it really points to, when you think about a well-designed and effective telemedicine program, the most important part of that is the program and its understanding the scope and capabilities of what a telemedicine physician can and cannot do, and then planning and making sure you have the right team members in place to manage the things where you need to have your hands on. And when you do that in a well thought out, well-designed program, you can take care of very sick patients, manage emergencies, but you can get to the bedside very quickly through telemedicine. So we're very proud of those programs, and it really laid a lot of groundwork for us in terms of understanding how to manage very sick, very urgent, very emergent, very acute patient care. So moving on to the kind of the meat of the presentation here. So rural healthcare at a glance. And as I said, we'll be sharing some data that I know will be no surprise to this group, but I do think it's important just to kind of set the scope of the discussion. So when you look at the United States, roughly 19% of residents in the United States live in rural spaces. And by definition, those are almost always underserved. And when you look at the access that rural versus urban has in regards to number of just physicians or number of specialists, about a 60% reduction in access to just a physician in rural areas, but almost a 10x reduction, 9x reduction in terms of access to a specialist. And I think that becomes really important when you look at managing an ever-growing complexity of patient in a physician-strapped environment. There's growing complexity, growing acuity in the patient base, but there's less and less support to manage that ever-growing complexity and acuity. And so we feel that telemedicine is a great way to match and really take the kind of overpopulated or overbuilt urban specialists and match them to the rural spaces. And that's largely what our 220 programs do, is take that that mismatch and bring them together so that there's more equivalence in really tackling that disparity. But just when you step back and you think about the numbers of people, 19%, while a small number out of 100, in a country the size of the United States with 330 million people, that's roughly 60 million people that just because of where they live are not receiving the same level of access to physicians and specialists, almost a 10x reduction in access to specialists than their urban counterparts. And when you think about 60 million as a number, that is the population of France or England. So it's an entire country, and it's an immense problem that is definitely worthy of pursuing and addressing with a very aggressive fashion. And that's where we find ourselves at Access Physician doing. So when you look at it, you take those same numbers and you look at them in a graphical format. I think this piece does a really good job of just looking at the scale of difference. On the left there, you see just in blue per 100,000 people, 131 physicians in the rural spaces, and in orange per 100,000, it's 312 physicians for those who live in urban. On the right, when you look at just access to specialists per 100,000 people, the blue again is rural. So out of 100,000 rural residents or people, you have access to 30 specialists, where in the urban environments, you're almost 270. So very immense. Again, I recognize that I'm preaching to the choir here about the disparities in rural healthcare, but it's very important because we believe that so much of the decisions in healthcare are driven by physicians or lack of physicians, that by placing a physician at the bedside in a timely manner will help change outcomes. And so the tangible impacts that those who practice in rural healthcare live and feel every day in terms of the rural specialist disparity are the challenges faced in staffing and recruitment, the challenges faced in the costs of providing coverage, the challenges faced in transfers, not having the right bench of medical staff to help address transfers or reasons for transfers, which directly can impact hospital census. It also will impact severity of illness as specialty patients and higher complexity patients leave the community. Most patients want to stay in their home community. And so it's also a driver of satisfaction, not only satisfaction with their immediate care, but satisfaction with their healthcare access, which is very important and can drive where some choose to live. And then obviously there has to be some sort of tangible impact on investing. And so that's got to be easily calculated. But each of these things goes into thinking about a telemedicine program and selecting what's the best program, what's the best fit, where do you start if you've never had a telemedicine program. And so as we think about telemedicine programs, and really the first step we have, and I would say this is step one as we work with hospitals, is looking at the transfer outs, recognizing there's many different things that can be looked at, but the ED transfer log oftentimes is the most important piece when we're doing our due diligence in meeting with hospitals to explore where are the opportunities. We feel very strongly that two things really need to be satisfied for a clinical program to be started. One, there has to be an absolute clinical impact that everyone can recognize. Secondly, it has to be a financially sustainable program. And kind of enveloping all of that is there has to be complete and total buy-in from the medical staff, the executive leadership, as well as nursing leadership and nursing staff as well, that this is the right thing to do. And so we find that when you can check all of those boxes, specifically, everyone agrees clinically, everyone sees financially this makes sense and is sustainable for the hospital, then we really refer to that. That's the low-hanging fruit program that really should be sought after first. And the first step, obviously, is looking, as I said, at the ED transfer logs and looking at the transfer process, but then really kind of thinking about what's going out and then rank stacking whatever is either procedural or lower volume and prioritizing what are higher volume or those that you can build consensus around. It's very important to build consensus, as I said, so that when a program goes live, everybody is a stakeholder in its success. Everything new is change, and change is always difficult and challenging, and it's always fraught with barriers. And there will be always missteps or issues that need to be rectified whenever something is new and changed, but it's really the goal of, the team that's helping lead an implementation to minimize that as much as possible so that everyone is on board. Everyone understands as soon as we see an issue, we're all going to rapidly jump in, course correct, and fix it, because you only have one opportunity to make a good or slam dunk first impression. So it's so important to select the right program. And so as we've worked through the telemedicine landscape, specifically focusing on inpatient care over the last decade, we've begun to see patterns. And oftentimes the patterns that we see follow disease prevalence and follow size and geography of the hospitals that we're working with. And in the rural hospitals, specifically critical access or small rural, cardiology has tended to be the number one reason for transfer. It's been one of the most impactful programs that we can implement in either critical access hospital or small rural hospital. And I think when you think back to disease prevalence, cardiovascular disease being the most prevalent disease in the United States, it makes perfect sense that the complications of that disease are probably going to be the number one reason for presentation to an emergency department. And if there is not the right medical staff to manage and support the attending physician, then it will also lead to probably the highest level or number one reason for transfer. And so that's what we're here to talk about today. But all of that being said is really to give the background, both the kind of epidemiologic data, but then also the experience that we've had in terms of launching programs and working through thinking about what is the best place to start. And so wanted to show this, and we can share this with attendees, or you can go to our website to review. We had a case study written up about one of our earlier telecardiology programs. And I think the great thing about this is a hospital that had a cardiology program. Like many rural hospitals, they had cardiologists who lived 30 miles away and would come to their community and hold clinics, round on inpatients when they could. So it wasn't a hospital that was without cardiology. They weren't starting from zero. They actually had doctors who were holding clinics several days a week and who were also rounding the hospital when they could. But as many of you know, patients present 24/7, 365 days a year. And unless you have a true program that can take care of patients when they present, when they need them, oftentimes many are going to slip through the cracks and have to be transferred out. And so by buttressing what they had and delivering a hospital with 365 days of consistent telecardiology coverage, and we were able to retain over 100 patients that otherwise would have transferred in less than a year. So I think this is I'm not going to go into the details with Cuero Regional here, but it's a great case study again on our website where you can read about the impacts that were had. But it's one we really like to point to because it's a very common setup that we see in terms of it's part of a program, but it's not necessarily a complete and full program, but it can still be very successful. And when you think about, as I said earlier, the scope of a program, I think many people think of cardiology as emergencies, going to the cath lab, or procedures being done like cardiothoracic surgery or pacemakers or defibrillators or cardiac ablations. But the majority of cardiology and care of those with cardiovascular issues in the hospital is actually medical. And so when you think about that, that's a very traditional, non-invasive general cardiologist. And it is managing primarily three disease states: patients with heart failure, whether it's a preserved or reduced ejection fraction, patients who present with chest pain, and even those who have a positive troponin, who are not a clear acute coronary syndrome, maybe a type 2 MI driven by hypoxia, sepsis, or some other secondary cause that's driving cardiac stress and strain, and those with atrial arrhythmias, such as atrial fibrillation, atrial flutter, or supraventricular tachycardia. Really find that that's probably 90% of what presents to an emergency department, and it really falls well within scope of a telecardiology program. Again, a non-invasive general cardiologist who's who's evaluating a patient, having an encounter, reviewing the record in the EMR, doing a traditional consult with daily follow-up and daily progress notes, who's putting their own orders in, really managing a patient as if they were there in the flesh and blood, but doing it through remote access systems, whether it's a telemedicine cart or remote access to the EMR imaging systems within the hospital, but able to document and put in orders and manage just like they were in person. So it's adjusting medications, work up through cardiac echo, which can be read same day, stress tests, whether they're nuclear echo stress tests or ECG treadmill stress tests, reviewing, having those performed and read out same day. So again, providing all the services that a non-invasive general cardiologist would provide, but doing it through telemedicine. And again, 90% or so of those patients, which is why so many patients can be retained. And we see that that's really the low-hanging fruit that we often run into in rural hospitals, because so much is managed medically. And again, when you think about scope of a program and designing a program, we aren't going to change through telemedicine or telecardiology how we manage patients with true cardiac emergencies. Those with ST elevation MIs are still going to be stabilized in the emergency department and sent out to cath-capable hospitals where they can receive PCI. Those with ventricular arrhythmias, which is often a sign of a very sick heart, or a patient with ongoing ischemia, he needs to go to a cath lab, who needs access to either an EP or cath lab. Again, those will transfer out. Those with cardiogenic shock, whether it's ischemic or non-ischemic, would benefit from a hospital where if they needed some sort of support device or needed to go to cath lab or the operating room. And then lastly, those who are post-cardiac arrest. Unfortunately, those being the most severe, most acute presentations, typically 5 to 10% that would come to an emergency department, which leaves the remaining 90% as heart failure, as I said, either preserved or reduced ejection fraction. Again, chest pain syndromes, and specifically troponin positive type 2 MIs, and then those with atrial arrhythmias. And oftentimes there's an interplay between all three of these, where a patient may have atrial fibrillation that has sent them into heart failure and caused a elevation in their troponin, where you have a mixed picture, which is probably almost as common as any of these presenting alone. But it's a great use case for telemedicine and telecardiology specifically to deliver equivalent, evidence-based, guideline-driven care that is truly state-of-the-art in terms of its delivery via telemedicine, but is also adherent to the best scientific data that's out there. And so just as a quick review, we see that a successful telecardiology program, as I said, has clinical outcomes, but also has financial outcomes. And so when you think about it, it's improving some items that are positive for a hospital, and it's working to reduce the other drivers that are negative for a hospital. And so we put in this very simplistic arrow up, arrow down, but it improves access to specialists. It improves clinical outcomes. It can help drive hospital census. It can aid a hospital's comfort level with handling a higher acuity and managing a higher acuity illness. Because it's through telemedicine, the cost is substantially reduced as compared to typical in-person, which oftentimes is an unachievable thing for hospitals, is bringing in-person cardiologists 365 days a year. It reduces the time that it takes to have a patient seen by a provider, specifically a specialist like a cardiologist. And that time reduction can also help drive a decreased length of stay. Appropriate care with appropriate follow-up driven by a specialist can help address readmissions. And it certainly, as I illustrated in that case study, can help reduce the emergency department transfers. And so when we think about kind of all of these things coming together, it's best delivered as a package, as a program. And that's really something that we really have focused our group on in our relationship with hospitals. And I think when you think about choosing the best partner, having a kind of single point for technology and support of that technology, implementation of that technology, management, recruitment, and onboarding of the physicians, and an overall program guidance, really find having all of that tied together, because there's such a tight interplay between the three, is important to having a successful telemedicine program in the hospital. And a few details just that we feel are kind of guidelines in terms of when you're going through the selection process. Obviously, security, when you're thinking about technology, security and HIPAA compliant communications, the provider should be working within your native EMR. We feel like that's a best practice in telemedicine. It's very important that the notes that the provider, the telemedicine provider, is leaving look and feel just like the rest of the medical staff. That helps with adoption. It helps with assimilation, where they're viewed as peers. But then also, it's important for the provider, the remote provider, the telemedicine provider, to be doing their own order entry. We find that both the documentation with initial consult notes, the daily rounds and those notes, as well as the order. The orders are really what facilitate true equivalent management, very important. Obviously, the telemedicine system, the platform that you're using has to work. If it doesn't work, or it's fraught with issues or challenges, if there's downtimes, that can really harm a program's reputation, which then leads to decreased utilization. And then it almost becomes a hood ornament that's just sitting in the cart becomes a hood ornament that just kind of sits in the emergency department or one of the hospital wards. And so our group, one of the first things that we did was actually build an IT division. So while we're a clinical services company, a physician group, we have 15 US-based FTEs dedicated to making sure the carts are always up and working. And so we've been very proud to say that our systems have had a 99.998% uptime over the past 4 years. And our average time to resolution, if there is an issue, has been between 2.7 and 3.2 minutes. And we manage that all internally. And again, that metric is actually focused on our because we have the high acuity code blue programs. And so we do not want downtimes longer than one cycle of ACLS so that we can always take care of patients uninterrupted. So there's a lot of people behind driving that uptime, but there's also a lot of redundancies in making sure that if there is ever a failure point, which is technology, so you are assured to have a failure point, that you're back up and running in real time. Simplicity is important to any piece of technology in the hospital. Staff are challenged with ever-growing numbers of technology and their workflows every day. And so for us, limiting the clicks that the on-site staff have to work through was paramount. And so currently today, we're very proud to say our cards are a zero-click technology. It goes without saying that they have to be high quality audio and video. So HD quality video so that the patient can see you as a provider and you as a provider can see the patients very clearly. So it's great cameras and great screens. And then obviously microphones that are built in to pick up all of the noises within the room, as well as the communication and voices of your patients. But then also great speakers so that your voice can project in a busy ER, ICU setting, loud ward, any of those so that you can communicate. That's the fundamental piece of an encounter, as everyone can imagine. And then any necessary add-ons. So we find that, especially in a telecardiology program, a stethoscope, very important. So when you think about having an interview with a patient at the beginning of your encounter, following that up with a thorough physical exam, which includes auscultation of the heart, the lungs, the abdomen. And so we use a digital amplified stethoscope so that our cardiologists can listen to the heart and do a true cardiac exam. And then obviously working with the nurse, who's our hands, look at pedal edema, feel for pulses, to do a complete and thorough exam. From a security standpoint, no data should be stored, shared, or sold. And really the physicians themselves should look and feel, act, and be part of the medical staff. And the last thing to say is talked about it, but the support in making sure that the carts really have zero downtime or as close to zero as possible is paramount to a program being well received by not only the patients, but by the hospital staff, the attending physicians who are the referral base, as well as the telemedicine providers who can also get frustrated. This is their full-time job and they want it to go as smooth and work as well as it possibly can. So those are our thoughts in guidance in terms of technology. When we think about program guidance and how a program should be built, as I said earlier, it has to have clinical as well as financial outcomes that can be tracked and trended. The clinical outcomes obviously are specific to each clinical program. And so those will be kind of worked through what are the important clinical metrics that the hospital wants to set. we'll also work with the hospital to make recommendations on what we've seen be successful with other client hospitals, but then also tracking that to financial outcomes. There has to be an ROI for hospital, otherwise it's going to be a short-lived program. And so Access Physicians, again, as I said, 220 programs in 22 states. We have had a 99.65 renewal rate since the inception of our group. We've only had 5 contracts non-renew since 2013. We're very proud of that number, but I think it points very much to our adherence to clinical and financial outcomes being tracked, measured, and the program being tailored to make sure that they're achieving those outcomes every month. And so every program undergoes a monthly review in concert with our hospital partner to assure that we are hitting metrics, and it's people working with people, managing people. And I think everyone can understand that there's variations in that have to be managed and adjusted. And so it's an intense part of what we do after we go live. And I think any partner that you work with should do that as well to assure that the group is continuously providing value to the hospital. And that how you provide value, how you define value will change over time. And it certainly has with us, as we have clients that are now in their 8th year of telemedicine programs. And if you look at them, how they are today versus when we started, they're drastically different, more complex. But we see that as providing an ever-growing value. Measuring satisfaction at the patient level, measuring satisfaction at the staff level, and then measuring satisfaction at the hospital leadership as well as the attending or referral base, understanding that value is being provided consistently to all of those stakeholders within a telemedicine program is also critically important to the longevity and success. And then lastly, the technology metrics and making sure that you're adhering to uptimes, resolution times and response times are meeting the goals. And as I said, it's a continuous process that's a partnership between our group and the hospitals, and should be between any hospital and their selected partner from telemedicine. Again, it's people managing people, working with people, and there's always a ton of variables there, and healthcare is always stressful, especially in these times. So it's important to have a partnership approach to that. And I think coming to the end here, so much in healthcare and healthcare IT is focused on the technology. And as I said, without a reliable cart that can provide the service, you cannot have a telemedicine program. But it's not the technology per se that drives the care. It is a tool, much like a stethoscope was a brand new piece of technology in the 1800s. Telemedicine is a brand new piece of technology that's applied to improve patient care today. But it is a tool. It can do any number of things. It improves access. It allows us to deliver care at a lower cost. It helps keep patients in their home communities, which is obviously not only good for the patient and their family to receive care locally, but it's good for the hospital. And oftentimes in these communities, we want thriving hospitals because they're one of the top 1, 2, or 3 employers and provide a lot of health to a community as a whole. And these thriving hospitals are what are going to help assure that we have viability long-term of rural healthcare. But just buying a cart and implementing a cart is not sufficient. It is really about building that program, and it starts with thinking through what the low-hanging fruit is, where can we get buy-in of all stakeholders, working diligently to assure that everyone is ready to have their best foot forward to make the best impression on day one. And then making sure that you have completely engaged, aligned, well-trained physicians who you can be proud of providing the telemedicine care. And the physicians within the program provided through the technology, all of those pieces is what leads to a successful telemedicine program, and where we've really seen success in these telecardiology programs. And so things to think about just as you're evaluating, maybe you have a ongoing telemedicine program, but kind of checking the ROI there is increased revenue from admissions, ADC growth, pre-post implementation. Are you able to help drive outpatient follow-up? That's an important piece of a telecardiology program when you think about outpatient echoes, outpatient stress tests. Starting outpatient cardiology clinics is an opportunity as well, where we've seen through telemedicine, or aligning a telemedicine inpatient program with existing outpatient physicians who may be coming from out of town who are aligned with the community and doing things just can't be available. And then also we've seen a good use in telecardiology in terms of preoperative evaluations in real time, where next day pre-ops can be done for those who need preoperative evaluations, and that helps reduce the cancellations and delays in surgical procedures for a community. And then lastly, keeping patient care local. We think that that's very important. I can imagine I'm speaking to a group who completely agrees with that. But telemedicine has been a great tool to reduce transfers, keep more patients local, which results in more local care. So I'll pause there and open it up for questions.
I have one question. It comes from Mike Easley. If I have a local cardiologist who travels to the hospital, could he use your technology to eliminate windshield time?
Yes. So short answer is yes. Long answer is that's I think really kind of one of the first things we do when we meet with a hospital is find out what the resources are in terms of medical staff from a specialty standpoint. And then if they have a resource, the next question is, would that physician, would he or her like to participate in the program? Because we strongly believe that so much of healthcare is relationship driven. And if there's a positive, healthy relationship and it's just geography getting in the way, that absolutely we support. So about 20% of our relationships with hospitals, we're the technology team that helps build a program, but not necessarily the providers providing the care. Or we're part of it and we're working in a hybrid relationship where local resources are participating and then we're filling in where they may not be able to fill gaps. So maybe night coverage, weekend coverage, or doing week on, week off. So there's a lot of different variations and we try to be incredibly flexible, but short answer is absolutely yes. And it's a question we ask in every relationship because we feel like those with existing positive, healthy relationships are the first choice always.
So are you saying then that your doctors are 24/7?
In various programs, they are. Typically in our cardiology programs, especially those in rural critical access hospitals, it hasn't been necessary. The volume just hasn't supported the need to have one on call, and we work with hospitals to create protocols to retain cardiology patients overnight. But yes, many of our acute stroke programs, our pulmonary critical care programs, our hospitalist programs are all 24/7 programs.
Can you tell me which East Texas hospital or community that you served at CMO?
Sure, absolutely. So I had the pleasure from 2012 to 2017 serving as a chief medical officer for the hospital in Sulphur Springs, Texas, which for the first 3.5 years of my time there was Hopkins County Memorial Hospital, which was a hospital district, and then it was there during the transition and stayed on a year after the hospital became what is now Christus Mother Francis Hospital, Sulphur Springs, and we have a very deep relationship with that facility. It was actually our very first program there. We currently have a 24/7 hospitalist program that does about 1,200 encounters a month. That includes a tele hospitalist program overnight, a tele ICU program, which has been running for 8 years, 24/7, completely virtual, tele infectious disease, and a 24/7 acute stroke and tele neurology program.
Well, that question came from John Henderson, the president of the Texas
Thanks, Sean.
TORCH, Texas Organization of Rural and Community Hospitals. So he was, yeah, I'm sure he knows the area well. Can you tell us one of your success stories without violating HIPAA?
Yeah, so I think the one I like to talk about a lot is our first success story. And as I said, started as a physician, had a different trajectory in my life. And our group began working in East Texas as an in-person group, working as hospitalists. And over a 1.5 years or so, saw a hospital that had 96 beds, had a 10-bed ICU, but ran an average daily census in their ICU of 2. And their number one reason to transfer patients was pulmonary critical care. And we felt that if somehow we could get 1 or 2 pulmonary critical care physicians in that community, that we could have a census of 8 to 10 at any given time throughout the year. And that would be an incredible benefit to the hospital. And so we actually worked for 1.5 years to recruit and came up with the exact result that so many in rural healthcare face, which is we could not find the right person to fill the role. And so, really just failed at recruiting an in-person traditional pulmonary critical care provider. And we're pretty frustrated by that. But thinking about what my experience had been in medical school at Texas Tech, where I saw patients served through telemedicine in 2002 and 2003, went to the hospital and said, if we buy the technology and kind of manage all this, would you permit us to at least try and see if we can retain patients? And so we worked for about 1 year to get that off the ground and launched our first program in 2013. And on night 3 of having that service live, Dr. Preetam Ghosh, who's right here on the screen, who was one of our very first physicians, is still with us today as our pulmonary critical care service line chief, was on call. And he got called by the ER, and it was about 2 in the morning. And the ER said, we have a patient. Normally we put this patient on a helicopter and they would go to one of the large transfer centers, whether it's in Tyler or Texarkana or Dallas. And, but would you like to admit this patient? He said, absolutely. He's a board certified pulmonary critical care physician. That's what he does every day. And this patient was in hypercapnic respiratory failure, was septic due to pancreatitis, and was about to be placed on a ventilator, was acidotic, and was really failing. The patient was admitted to the ICU at 2 in the morning. And at the same time, they called the family practice physician who was on call. And that physician was taking home call, like so many rural hospitals, and bylaws at that time required that if a patient was admitted to the ICU, that the attending physician had to come in and see that patient within a short window. And so he, living at his home, kind of got everything together. It took him about an hour to get bedside. And in that hour, Dr. Ghosh received the patient, resuscitated the patient, stabilized their acid-base issues, stabilized their hemodynamics, and began cooling off their respiratory failure so they didn't have to be intubated. And when that physician who was on home call came in, the family practice physician came in, he literally stood at the bedside for about 30 minutes and just watched. And this was about 2:30, 3 o'clock in the morning. And he said, I guess I don't have to do anything. He turned around and went home. And Dr. Ghosh kind of managed the patient throughout the rest of the night. And the next morning, I received phone calls from the physician who took the overnight call, who witnessed this. I received phone calls from the ICU director. I received a phone call from the CNO, and I received a phone call from Dr. Ghosh, all saying, you will not believe what happened last night. And that was the moment, I think, in our group where we completely saw an opportunity that this actually may be a tool that can help address these issues that we've been seeing for so long in rural healthcare. And so we spent 1 year after that patient experience focused solely on that ICU, seeing if we could build programs that we would be proud of in terms of handling very acutely ill, very complex patients that we would manage that we thought could only be managed by an in-person physician. And after 1 year, felt very confident that this could be scaled. But it was that patient experience that night that we've replicated many, many times, and now build these types of programs in urban cities. I think our largest city where we have a similar program is in Dallas, at a 250-bed hospital where we manage their ICU 100% remotely at night and have telemedicine with a in-person nurse practitioner during the day. Really speaks to how you can, when you develop the right program where you understand scope of a telemedicine provider and scope of the in-person team and how they come together to form a program, you can really manage sick patients. But it all started with that very first encounter at that hospital in Sulphur Springs, and really proud of that moment, proud of the team, and love sharing that story. So thanks for the opportunity.
A great deal of the success that you feel was also felt by the patient in that case. That's an amazing
Absolutely.
opportunity for care, especially in areas where it's so underserved. Do we have any other questions from anyone? Please send in the chat. We're getting comments saying that they're impressed. Where do you see your organization going in the next 5 years?
So the landscape of telemedicine has changed dramatically in the last 5 or 6 months. I think it's accelerated by anyone's measurement the adoption of telemedicine. So we're going to see a rapid increase in the application of telemedicine and the expansion of the ability to have professional fee billing across all care settings. I think will lead to a rapid growth of telemedicine, both in rural areas as well as urban areas over the next 5 years. And so there's legislation now that has been presented and passed through the House, the Protecting Access to Post-COVID-19 Telehealth Act, that we feel if it passes through both houses of Congress will be a paradigm shift in care that can be delivered to patients. And so really our goal as a group will remain the same. And it is really a mission-driven organization that has a vision where telemedicine really becomes part and integral to the delivery of healthcare within hospitals. And that's where we feel like we can be a thought leader, where we can be incredibly impactful to hospitals as well as patients together. And we're incredibly excited about the opportunities now afforded. I think whenever you look at a tragedy, and by all accounts, what we're all facing and dealing with right now is a tragedy in terms of infectious disease and loss of life. But oftentimes out of tragedy, it changes and it opens opportunities that we just wouldn't see before. And I think that we've now seen that less than 15% of physicians had worked in telemedicine 6 months ago, now over almost approaching 60% of physicians. And the uses of telemedicine have gone from the tens of thousands a week in inpatient settings or across the board to millions. And those are important changes for the healthcare system. It's opened everyone's eyes to what's possible, and it will drive, we believe, a paradigm shift in the role of telemedicine within hospitals, but also just patient encounters in general. So we see continued growth. We're going to be true and stable to our 6 core service lines, and continue to pursue to provide the highest quality programs to the hospitals we work with.
Not in your wheelhouse, so I'm not expecting you to be able to give a definitive answer, but I work with students who are pre-med and med. Do you think there'll ever be a time when a student could be a part of a program such as yours, and that would also count toward fulfilling their rural medicine component to help with their funding of their education?
I think it's a great question. So we, as a group, had the opportunity to work with a program, a family medicine program, where they work with our telemedicine physicians. So we've actually worked now with 2 different programs. One, an outpatient program where we had physicians, residents coming into our telemedicine clinic, endocrine and neurology and psychiatry, and training on telemedicine. And presently we have one in East Texas where family medicine residents are co-managing patients with in the ICU, our pulmonary critical care. So I think absolutely we're going to see, and that's happening all over the United States right now. And I think we'll begin to see telemedicine become an integral piece of the training. And we do see that today with those in neurology, vascular neurology fellowships, where they're focused on managing acute stroke, and acute stroke telemedicine has become really the gold standard to getting bedside and getting meeting your TPA and bedside requirements. So absolutely, and I believe I would have to think it's going to distill down to the medical staff or the medical students as well. I'm not aware, but certainly it's got to be starting now, I would have to think.
question from the audience. How much cross-training is done by your staff and physicians with the critical access hospital to ensure that the staff is able to act as an extension of the MD during consults?
Sure, it's a great question, and part of that implementation process. And so the training of the staff, I think, two parts. One is just getting comfortable with the cart. So it's very important for us to have a no-click solution from a cart standpoint. When we started, the cart on the nursing side was 13 clicks, and it was very complex. So engineered to where it was a no-click solution where the nurse just had to bring the cart to bedside, the remote physician could do everything remotely. That was important in terms of scaling and kind of reducing the intimidation factor for the nursing staff. So we will do mock encounters as we launch to make sure that the nursing is comfortable moving the cart, and most important is positioning the cart at the foot of the bed so that we can have a face-to-face with the patient. And then after that is really kind of letting nursing kind of relax, in that we're not going to ask nursing as our hands to do anything they're not already doing with their patients. Inpatient nurses are already doing bedside rounds on all of their patients at least once a day, and oftentimes multiple times a day. And they're doing assessments. They're using the same physical exam skills that physicians use. They're auscultating the heart in the exact same spots that we would listen to the heart as a cardiologist. They're auscultating the lungs. They're auscultating and palpating the abdomen. They're feeling for pulses. They're testing reflexes in those with neurologic issues. So it's really coaching the nursing and getting with them to make them understand that we're not going to ask for anything you're not already doing. These are already physical exam skills that you possess and competence you already possess. And we have engineered the technology to be as minimally intimidating as possible. And really all we need is for you to bring us into the room and then be at our side as we talk with patients. So it hasn't been so much as kind of getting them cross-trained is really kind of educating them on, we're going to listen to the heart the same way you listen to the heart, except you're going to hold our stethoscope instead of holding your stethoscope. And you just need to bring us to the bedside and we'll be able to take care of the patient and have an encounter. So I think those are the big parts. Obviously, it's taken a lot of work to get there over the last 7 years in terms of engineering, in terms of simplification. But that has always been the ultimate goal, is reducing the burden. Nurses have a lot to work with. I mean, a lot to do and sometimes little to work with. And the last thing they want is a doctor pestering them throughout their workday with complex workflows and a lot of detailed asks. So nursing's really become our best partner and probably our best ally in every one of our programs.
I think one of the takeaways from what you just said is that for those of us that are adjusting to online seminars, trainings, etc., there is hope that we will eventually master the technology. It may take 7 years, but we'll be able to do this.
Persistence, right? Persistence. That's right. Absolutely.
Do we have any other questions for Dr. Gallagher? Do you have anything you'd like to add, Dr. Gallagher?
I think the main thing is just, thanks and appreciation for the opportunity to speak today. Obviously, speaking on telemedicine specifically to those who understand rural healthcare is really our passion and my passion. So very thankful to be able to chat. And if you have questions, please, you can reach out to myself or any of our other team members. I think, spend all day talking about telemedicine, and happy to provide any guidance that could be beneficial. So thanks again for the opportunity.
We thank you so much for being here. It was informative. It was easy to understand for those of us that are not physicians but are passionate about rural medicine. And we appreciate your time and your expertise. Thank you.
Thanks so much.